The informed consent and request for surgery document involves 12 points that either Dr. Monteith or Dr. Berger will review with you in detail, and each of you will sign it. The 12 points are: I request Dr. Charles Monteith or Dr. Gary Berger to perform the surgical procedures described below at Chapel Hill Surgical Center. I understand the nature and purpose of the procedures. I understand that Dr. Monteith or Dr. Berger perform outpatient tubal reparative surgery through an incision that's above and parallel to the pubic bone. This is called a mini laparotomy incision. I'm aware that surgery has potential risks and/or complications. I've read and understand the accompanying form entitled Potential Risks of Surgery. I'm aware that in vitro fertilization is an alternative treatment to tubal reparative surgery. I understand the potential benefits and risks associated with this alternative treatment of IVF. I understand that there is no guarantee of the outcome following my tubal reversal procedure, and confirm that Dr. Berger or Dr. Monteith nor any member of the staff has given me any guarantee, warranty, or assurance regarding the outcome of the tubal reversal procedure. I understand that my fallopian tubes may not be able to be repaired, and if the tubes are repaired, there's no guarantee that I will become pregnant. I also understand that if I do become pregnant, I have an increased risk for a tubal or ectopic pregnancy. I'm aware of the early pregnancy monitoring protocol recommended by Dr. Berger and Dr. Monteith. I understand that unanticipated conditions may require additional or different procedures from those described. I request and authorize Dr. Monteith and his assistants, which may include Dr. Berger, to perform such additional procedures as are medically appropriate to protect my health and to promote my fertility, in order of that importance. I understand that Chapel Hill Surgical Center is owned by Dr. Gary Berger. I understand that surgical procedures at Chapel Hill Surgical Center are performed on an outpatient basis. Should hospitalization become necessary, I authorize Dr. Monteith or Dr. Berger and the employees of Chapel Hill Surgical Center to transfer me to the University of North Carolina hospitals, where I will be under the care of University of North Carolina physicians. In the event of hospital transfer, I authorize Dr. Monteith or Dr. Berger and Chapel Hill Surgical Center to share my medical information and records with the physicians at UNC hospitals to assist them in providing my medical care. I consent to the disposal of any tissue or foreign bodies such as tubal clips or rings that may be removed during my tubal reversal procedure. I consent to having my blood drawn and tested for HIV and/or hepatitis viruses should a needle stick or other sharp injury occur to a staff member during my surgical stay at Chapel Hill Surgical Center. Just to review this a little further so that I can explain what some of these things mean. The risk of complications at Chapel Hill Tubal Reversal Center is fortunately less than 1%. Rarely are there any type of serious complications, but with any surgery there are some inherent risks. Just to review those a little bit with you, any surgical procedure has the risk of possible complications and risks. Some of the general risks that could occur are postoperative infection that may require antibiotics or repeat operation, bleeding during or after surgery that may require blood transfusion or repeat operation. Other possible short-term risks include phlebitis, which is an inflammation of the vein, thrombosis, blood clots in a vein or artery, electrocautery burns, pelvic pain, injury to the intestinal or urinary tract, urinary retention, intestinal obstruction, hernia, and wound infection or separation. The primary risk associated with tubal reversal surgery is the long-term risk for an ectopic or tubal pregnancy. The ectopic pregnancy rate reported in the tubal reversal follow-up study is in the range of 10 to 15%. This is significantly higher than the ectopic pregnancy rate reported in the general U.S. population, which is around 2%. I have been informed of the importance of early pregnancy monitoring according to Dr. Berger's recommended protocol to minimize the risk of a ruptured tubal pregnancy. If I become pregnant, I will notify my local physician so that early pregnancy monitoring can begin without delay. I will also report my pregnancy to Dr. Berger by completing a pregnancy report form on the Tubal Reversal Center website. I understand that some aspects of surgery can be unpredictable. I'm aware that my fallopian tubes may not be repairable or repaired, and that there is a chance that blockage of my fallopian tubes may occur after surgery due to scar tissue formation, tubal infection, or other conditions. We then ask that you sign that you've read and fully understand the form, and that you've had the opportunity to ask questions and receive answers to any of your questions. A lot of patients call our office and ask whether they should have an HSG or a hysterosalpingogram following surgery. This is a test often called a dye test, where dye is injected into the uterus and should spill out the fallopian tubes to determine if the tubes are blocked. It's not necessary to have this procedure following the tubal reversal, but many women do want to have it done to make sure that the tubes have remained open following surgery. At Chapel Hill Tubal Reversal Center, there's approximately a 5% risk that the tubes will block again. We don't know why that happens in some women and not in other women, but there is about a 5% risk of that. For most women, if pregnancy hasn't been achieved within 8 to 12 months following surgery, we will ask for you to speak with your local physician about a hysterosalpingogram or the HSG. This should be done after your period but before you ovulate. So typically that's between cycle day 7 and cycle day 10. Dr. Berger and Dr. Monteith recommend some antibiotics for a day or two prior to the procedure and for a day or two following the procedure, as well as using a betadine douche the night before the procedure and the morning of the procedure. You may also want to use some ibuprofen about an hour before you go to have the test done. One of the problems with HSG testing that we see is that the x-ray is misinterpreted as the tubes being blocked. Unfortunately, if adequate dye isn't instilled into the uterus to fill the uterus to spill out into the tubes, there's no way to actually interpret whether or not the tubes are blocked or open. If the dye doesn't make it past the point on the fallopian tube where the anastomosis site is, so that's the place where the tube's repaired, then there's no way to know definitively whether or not the tubes are blocked. Following the HSG, we do ask that you send the films to our office so that Dr. Berger or Dr. Monteith can review them. Based on the information that they gain during your surgery as far as the proximal and distal lengths of the tube, that allows them to make a better determination, looking at the operative note and at the films, whether or not the dye did make it past the anastomosis site. In situations where the tube is confirmed to be open but the other tube is blocked or inconclusive, Dr. Berger usually recommends, and so does Dr. Monteith, continuing to try to conceive for several months without taking any other action. If both tubes are found to be blocked during the HSG, we offer repeat surgery at a reduced fee if there's still good tubal length remaining for a second repair to be performed.